to grow. 8 out of 10 Californians say that making healthcare more affordable is an extremely important or very important priority for the governor and the legislature. You may recall that a couple of years ago, there was legislation that would have regulated rates within the healthcare system. Let me be clear, this proposal does not do that. AB 1130's approach is based on data and transparency by creating an office responsible for collecting and analyzing information and establishing cost targets. In response to stakeholder feedback, we have minimized new data requirements and quality measurement standards to assure administrative burdens are lessened. We have adjusted the timeline so that no enforceable target will be in place until at least 2026 to allow the foundational work to occur and for healthcare entities to become comfortable with the process. The process of enforcement is not meant to be punitive on the front end. It's not punitive on the front end. It allows entities to work with this new office to develop a corrective action plan before enforcing missed targets with fines. The concept of a commission or office charged with cost containment is not a new one. There are 6 other states that have something in place already, and they are showing results. Yet, yes, these other states are not as large and complex as California, but we can no longer wait to address growing healthcare costs. There are still important issues with the proposal that have yet to be resolved, including the definition of which providers will be in versus exempted from the bill. My intent is not to capture every office or entity in the state, but rather focus on those groups or entities that are dominant enough if in an area that they have a significant impact on pricing. Having said that, the goal of this proposal is to include those entities in the healthcare space that are driving costs, whether by their size or geographic market influence. I'll continue to work with stakeholders on this issue, as I do with every one of my bills, to consider any other reasonable concerns. With me here in support today, Yasmin Peled and Beth Capel representing Healthcare Access, and William Kramer representing the Pacific Business Group on Health. I respectfully ask for your aye vote.
Let's move to the testimony and support.
Good afternoon, Mr. Chair and members. Yasmin Peled with Health Access California, the statewide healthcare consumer advocacy coalition. We are here today in support of AB 1130, which would create the Office of Healthcare Affordability. Every California consumer with private health insurance is being hit by the rising cost of healthcare, paying higher premiums, deductibles, and copays, and feeling the impact of stagnating wages. Healthcare costs are rising faster than general inflation and wages, and many consumers forego care because they cannot afford it, skipping medications, doctor's visits, lab tests, or other necessary care. The Office of Healthcare Affordability aims to take a holistic approach at containing healthcare costs, resulting from years of negotiations and engaging stakeholders about what can work. While we appreciated past cost control proposals that have tackled specific markets, Office of Healthcare Affordability would have a comprehensive view of the entire healthcare system. The office would set enforceable cost targets for the healthcare industry and have the ability to levy financial penalties or other corrective action if an entity exceeds the target. The targets would be set by sector and would take into account regional variation, recognizing the differences and complexity throughout California's healthcare system. Unlike rate setting, which says a doctor visit is a certain amount of dollars or a hospital stay is 150% of Medicare, the target serves as an overall goal the industry must meet, but provides the flexibility to achieve it in a way that works within the current structure. It also gives the industry the tools to improve quality and equity while reducing costs by emphasizing primary and behavioral care and alternative payment methods. This office does not single out any one part of the industry, but instead recognizes the role that hospitals, health plans, medical groups, and other parts of the health system play together in finding the best solution to preventing higher costs. The amendments taken today make progress in clarifying and improving the bill, and we look forward to working with the author's office on additional amendments that the advisory board is dominated by those that actually pay for the cost of health care. For these reasons, we are pleased to support this measure, and we respectfully request your aye vote.
Let's move to the second testimony.
Good afternoon to the Chair, Vice Chair, and members of the committee, and thank you for the opportunity to offer comments on AB 1130. I am Bill Kramer, Executive Director for Health Policy at the Purchaser Business Group on Health, formerly known as the Pacific Business Group on Health. We are a not-for-profit coalition based in California, representing nearly 40 large and private employers and public entities. We strongly support the proposed Office of Healthcare Affordability. All of you know what the problem is, that healthcare costs are too high, creating financial barriers for patients to get necessary care. It also puts a severe financial burden on employers that provide health benefits to their employees and families, thereby crowding out business investment and workers' wages. We know that healthcare costs could be lower, much lower, while maintaining the quality of care. Numerous studies have shown that the amount of unnecessary spending is 20 to 30% of total spending. We also know that some hospitals and physician groups are able to provide high-quality services at much lower cost than other providers. This bill presents a great opportunity to hold down the costs of care and benefit all Californians. In particular, we believe that the proposed Office of Healthcare Affordability will be effective because, one, its scope is broad, taking into account quality, access, and equity in addition to costs. Two, it will set appropriate cost targets with meaningful incentives for meeting those targets. And three, it will provide technical assistance and support to providers for help in meeting the targets. There is one element of the bill, however, that we believe needs to be strengthened. The role of the advisory board is very important to the success of the Office of Healthcare Affordability, and it is important that its members are acting in the interests of the general public. Specifically, the board should ensure that the interests of patients, consumers, and purchasers, those who receive health services and pay for them, are primary. I have participated in many advisory groups and boards that are composed of people who have expertise in the healthcare industry, but unfortunately, in these groups, the interests of consumers and purchasers are often overwhelmed by other interests. As a result, we are often stymied in our efforts to make progress toward our goals: lower costs, better quality, access, and equity. I strongly recommend that the committee consider changes to ensure that the advisory board is acting on behalf of the general public and in the public interest broadly. Thank you for consideration of these comments, and we would be happy to provide additional information and assistance if it would be helpful. Thank you.
Thank you very much. We are now going to go to the testimony in opposition. Who's up first for testimony in opposition?
It's Carmela Coyle. I'm happy to jump in.
Yes.
Thank you very much. Thank you, Mr. Chair, Vice Chair, and members of the committee. I am Carmela Coyle, and I serve as the President and CEO of the California Hospital Association. And I'm testifying today because the effect of this bill on the people of California and on you as elected leaders will be enormous. I'm also here because I led the Hospital Association in the state of Maryland for 9 years, a state that sets healthcare spending targets like those proposed in this bill. We recognize the importance of addressing the problem of healthcare affordability. On AB 1130, California's hospitals are opposed unless the bill is amended, because in doing this, we must be successful and not create unintended consequences that I believe will happen with the bill as drafted. We have offered to the committee an alternative to this bill to meet affordability objectives. While there are many issues, I hope you'll hear just 3 points today. First, it is critically important to be clear about what problem we're trying to solve. Is it healthcare costs? Is it healthcare prices? This bill does not address healthcare costs or prices. Is it how much we spend on healthcare? Is it how much we spend per person on healthcare? Is it spending by consumers or spending by employers? This bill, as an example, does not take into account the rate of increase in premiums paid by employers. So the bill is not clear on this really critical issue. California spends less per person on hospital care, for example, than the national average, despite having the third highest cost of living in the nation, and labor costs in California that are growing 10% faster than national health care spending. California spends 3/4 of what a state like Massachusetts spends per capita on health care, defining the problem that we're trying to solve. Cost, price, spending per capita is critical. Second, affordability won't be resolved. The bill limits the increase in healthcare spending in California, but how much we spend on healthcare is a combination of both the cost of care and how much care we provide to 40 million people. How do we separate and keep the good spending, for example, more for primary care, more for an aging population in California, while eliminating bad spending, unnecessary care, inflated drug prices? This proposal does not differentiate between the two. So do we provide less care to those in need in order to meet the spending caps? The bill will limit how much California spends on care, but not necessarily make care more affordable for a typical Californian. And finally, the unintended consequences of this proposal, if not amended, are real and serious. Capping healthcare spending suggests that today we're spending the right amount in the right places, and I believe that's not the case. For communities that are under-resourced, spending caps can lock in that inequity. We need to spend more on coverage and care for undocumented individuals. We need to spend more on mental health and substance abuse care for millions in California, especially after the pandemic. What is the next new technology, and when might the next deadly disease or pandemic arise? And a healthcare spending cap in California means that we are accountable for any healthcare decisions that are made in Washington, D.C., not California, related to Medicare or Medicaid or setting a federal minimum wage, drug pricing policy, or more. Any of those federal decisions can affect spending and trip the California cap. Our alternative creates a commission like the one in this bill, and just like Congress did to inform them and make policy recommendations on the federal Medicare program. The difference is that our proposal asks the commission, with data and expertise, to determine key cost drivers, what should be measured, how it should be measured, what should be limited, and what recommendations for specific policy change should be made to make care more affordable, with those recommendations going directly to the legislature. Those matters, we believe, should not be determined in advance without the data and the critical analysis, as could be done in this bill. So we thank the committee members for your time, and we do very much look forward to working with you on this important issue. Thank you.
Thank you, Mrs. Coyle. And moving to the second witness in opposition, and just making sure to, I didn't set my timer there, but just making sure to be good on time. Second witness.
Thank you, Mr. Chair. I will be brief. Mr. Chair and members of the committee, Brandon Marchi with the California Medical Association. We are currently opposed to AB 1130 unless it is amended. Physicians have been on the forefront of policy work to address the rising costs in healthcare. In 2018, the profession developed policy proposals that would create an efficient and effective healthcare delivery system that prioritized patient health, improved quality, and reduced costs. We are encouraged that AB 1130 contains some version of several of these proposals, such as the reduction of administrative burdens, the streamlining of quality reporting metrics, the encouragement of value-based care arrangements, and an increased investment in primary care. These sections of the bill, though still in need of refinement, will help to create cost savings for patients and improve the care delivery system. However, as written, AB 1130 is too broad in scope and fails to focus on those entities that are true cost drivers within the system. And still, the bill treats a single physician practice the same as a multi-million-dollar insurance company or hospital system, and does not take into account the corporate structures, operational differences, or the relevance of market share, which create significant variances in costs. Without more focused definitions in the bill that take these factors into account, the office will be bogged down by minutia and analysis of entities that do little to contribute to the ballooning costs of healthcare. Additionally, it is unclear why audited financial sheets are needed from providers, especially since relevant provider financial data is incorporated into health plan disclosures that already exist. It is unclear why the office would need these reports or how they would be helpful in carrying out its responsibilities. At this time, CMA urges that AB 1130 be amended to focus this new office on cost drivers within the marketplace, ensure transparency and accountability for the public and healthcare entities, properly promote competition, and ensure that proper incentives are given to the office's regulated entities to promote and adopt administrative efficiencies and move more patients into value-based care systems. We look forward to future conversations on AB 1130, and the medical profession continues to do their part to help control the cost of healthcare and improve healthcare outcomes for patients. Thank you.
Thank you. We're going to now move to the add-ons. This is both in opposition and support. So moderator, will you please open the lines?
Sure. If you'd like to make a comment, you may press 1 and 0 at this time. First, we go to line 191. Please go ahead.
With California Rural Legal Assistance Foundation in support of AB 1130. Thank you very much.
Thank you.
Next, we go to line 119. Please go ahead.
Good afternoon. Rebecca Gonzalez, National Association of Social Workers, California Chapter in support.
Thank you.
Next, we go to line 202. Please go ahead.
Good afternoon. Ronald Coleman on behalf of the California Pan-Ethnic Health Network in strong support.
Thank you.
Next, we go to line 203. Please go ahead.
Thank you. Thank you, Mr. Chair and members. Megan Subers on behalf of the Writers Guild of America West in support.
Thank you.
Next, we go to line 205. Please go ahead.
Good afternoon, committee members. This is Michelle Gill on behalf of California Immigrant Policy Center in strong support. Thank you.
Thank you.
Next, we go to line 204. Please go ahead.
Thank you. Amber King with the Association of California Healthcare Districts here with an opposed unless amended position, and we would align our comments made by the California Hospital Association. Thank you.
Thank you.
Next, we go to line 208. Please go ahead.
Good afternoon. Jen Flory on behalf of Western Center on Law and Poverty in support of AB 1130.
Thank you.
And next, we go to line 178. Please go ahead.
Mr. Chair and members, John Winger on behalf of Anthem Blue Cross. Appreciate the conversations, and I think we have some technical concerns, but we do support the concept. Thank you.
Thank you.
Next, we go to line 199. Please go ahead.
Good afternoon, Mr. Chair and members. Nicole Riddleman on behalf of the Children's Partnership in support of AB 1130.
Thank you.
Next, we go to line 201. Please go ahead.
Good afternoon, Mr. Chair, members of the committee. Laurie Nolan-Hajek on behalf of Blue Shield of California in support.
Thank you.
Next, we go to line 200. Please go ahead.
Good afternoon. This is Juan Rubalcaba with the Alliance of Californians for Community Empowerment, calling in support.
Thank you.
Next, we go to line 151. Please go ahead.
Thank you, Mr. Chair. This is Bill Barcelona representing America's physician groups in a support if amended position.
Thank you.
Next, we go to line 209. Please go ahead.
Good afternoon. Preston Young from the California Chamber of Commerce here today in a support if amended position and look forward to working with you on that. Thank you.
Thank you.
Next, we go to line 112. Please go ahead.
Good afternoon, Mr. Chair and members. Connie Delgado on behalf of the District Hospital Leadership Forum, here with an opposed unless amended, aligning our comments to CHA.
Thank you.
Next, we go to line 197. Please go ahead.
This is Neil Rubenstein from the National Multiple Sclerosis Society in support.
Thank you.
Next, we go to line 189. Please go ahead.
Nick Luisos with the California Association of Health Plans. We don't have an official position at this time, but wanted to thank the chair for accepting our input, and we appreciate the prospect for further feedback opportunities. Thank you.
Thank you.
Next, we go to line 161. Please go ahead.
Good afternoon, Chair and members. Megan Loper on behalf of the United Hospital Association with an opposed unless amended position. Thank you.
Thank you.
Next, we go to line 101. Please go ahead.
Hi, this is Janice O'Malley with the California Labor Federation. We are in support of amended, and we look forward to working with Dr. Wood's office in ensuring that healthcare cost targets will not adversely affect our healthcare workers. Thank you.
Thank you.
Next, we go to line 121. Please go ahead.
This is Mira Morton on behalf of the California Children's Hospital Association. We're also opposed unless amended. Thank you.
Thank you.
Next, we go to line 212. Please go ahead.
Hi, this is Vivian Kwok with Justice and Aging in support of AB 1130. Thank you.
Thank you.
Next, we go to line 207. Please go ahead.
Can you hear me?
We can hear you.
There, this is Bianca Bloomquist with Small Business Majority. We'd like to register our support for AB 1130. Thank you.
Thank you. Thank you. And just as a reminder for any of those that are just tuning in, we are on AB 1131 Wood, and we're taking, I'm sorry, I'm looking at the wrong thing, yes. And 1130, not 1131. And we are taking those who would just register their name, their organization, and whether they support or oppose the bill. Mr. Moderator.
At this time, there are no others in queue.
Well, then that was easy enough. Now we'll come back to the committee, and I want to recognize Mr. Mainshine.
I'm not sure. Yeah.
You're on.
Okay. Thank you. Mr. Chair, I'm supportive of, of I think where you're trying to head or the concept behind this. I do have a few questions, though. What would be your response on whether this would tie this into sort of a moment in time? And by that I mean in terms of, let's say, reporting, right? Where we'd be tied into sort of standards that exist today versus in terms of technology or other things might exist tomorrow. And on that note, too, I'd just ask you to respond to the point raised, and I have a follow-up question, but at least start here. The point raised about the relationship with the standards that would be set down by the federal government. I think currently, obviously, tend to be in line with the current federal administration, but that might not, based on past experience and what we could anticipate possibly in the future, that might not always be the case. So I'd like to get your responses on kind of those two related points.
Well, let me get to the second one first, and then I lost you on the first one. But so on the second one, if there are federal recommendations and out there, there isn't anything in federal law at this point. So we as a state, the federal law sometimes is the floor, not the ceiling, and so we would obviously need to, if we were in conflict, we would need to rectify that if we were trying to be less or more lenient than the federal government. So the idea that, and part of what I heard in the opposition testimony was, well, maybe we should just have a commission, that makes all these recommendations and then send those to the legislature. I kind of would argue that's what's happening now. And it's extremely difficult to move these policies because every time you move a policy, there's huge opposition from whatever entity is out there who might be affected by that. So going to your first question, and I apologize for.
Yeah, maybe I was vague on that. What would you respond? CHA and I think CMA also mentioned, at least on a couple of the points, having proposed some sort of alternatives. Have you had a chance to review those, and what are your thoughts on that as it moves forward through the process?
Well, yeah, and the alternative, which was put forward by CHA, is exactly what I just described. Let's have a commission that actually looks at these issues and then makes recommendations to the legislature. We don't have a commission that does that. Instead, we have an alphabet soup group of advocates out there that do that now, present us with ideas, we run with them, and here we are with skyrocketing healthcare prices. So that system isn't working as well as we would like to see it. As far as you asked about like a snapshot in time, we're sensitive to the fact that we're in the middle of a pandemic. Yeah. And so we recognize that we couldn't set targets or goals based on where we are now, but we can certainly gather data and information about what's going on out there. And then when we, God willing, are in a better situation out there, we'll have a way to begin to tabulate that data, future data, that we can work with out there and base things on that. The idea of creating goals.
Okay, and you did right there. That was actually a response to what. So you did understand what I was saying. Maybe, okay. So no, that's what I was kind of getting at was, particularly this year, obviously would be an aberration on a whole right. host of levels.
Right. The way the bill's been amended, it's going to be 2026.
Yeah.
I won't be here. Well, I might on the way out the door if it doesn't hit me.
Yeah. No. Okay. Thank you. I appreciate your work on this, and certainly we'll want to keep working with you as this moves forward. But thank you for your responses, Mr.
Great.
Chair.
Thank you.
Thank you, Mr. Mainshine. Anybody else with questions or comments? Mr. Nazarian.
Thank you, Mr. Chair. Mr. Chair, thank you so much for bringing this bill forward. I will support it, and I'm looking forward to seeing it move forward. My only concern, and I briefly brought this up to you just today, was about the fact that how this bill potentially impacts some of the children's hospitals around the state, given the important work that they do, given the safety net that they provide. My concern would be that I think the regular hospitals can work through and figure it out, but the children's hospitals, given the sensitive communities that they address, that's where I had some concerns, and would love to hear from you on that. Thank you.
Well, thank you for that question, Mr. Nazarian. And what we envision is actually subsectors. Hospitals would be a sector and subsectors, recognizing the critical importance of children's hospitals, critical importance of our UC hospitals, our community hospitals as well, so that there would not be a one-size-fits-all approach to all hospitals. We want to recognize that there are settings like children's hospitals and teaching hospitals that have higher costs, and they just take more to run, and we recognize that. And so we would envision these being in subsectors, but we don't envision exempting, because I still believe that there is potential for savings through efficiencies and elimination of waste.
Looks as though Mr. Nazarian has completed his comments. Any further questions or comments? Ms. Burke.
I don't know if this, oh yeah, my mic's on. I just wanted to be added as a co-author and just wanted to put that on the record. Thank you.
Thank you. Be happy to have you.
Ms. Aguiar-Curry. Oh, no, did she want to be added as a co-author as well?
Thank you.
Any further questions or comments? I just have one I wanted to ask you, Dr. Wood. It was brought up actually in the opposition, talking about, the name of this is the Office of Healthcare Affordability. And it was said that this wouldn't look at all at any labor costs or any other costs like the earthquake requirements and so forth. Is this limited in any way, talking about affordability, or will this office be able to dig into anything that is going to create costs?
We envision broad authority, and we envision a robust working group of advisors that can look at everything, and recognizing, earthquake, seismic is an issue, and other things are issues. So we envision this as fairly broad in its approach.
Great. All right, going back to the committee. Did we have a motion on this bill? I know we had a couple. A motion by Adrin, second by Ms. Burke. I'm sorry, Mr. Nazarian made the motion. Ms. Burke seconded. With that, clerk, please call the roll.
Whoop, hang on.
Oh, I'm sorry. You want to close?
If you don't mind, I'd like to close. And I'd like to close by reading something. And first of all, I want to thank the committee for their questions or comments. I want to thank the witnesses for their questions and comments. But I want to read to you, this came out today. California Healthcare Foundation blog, and it's entitled, "Aligning Healthcare Cost Growth with Economic Growth Would Save California Billions." That's billions with a B. So I'm going to read this because I think it's significant. Fortunately, let me find the right, I'm going to read if I can find it. If California sets and achieves a cost growth target like those we're starting to see in other parts of the country, there is a chart associated with this, and I'm happy to provide you the links. As the focus, I can find it. I apologize. I really hate it when things are printed on both sides. Okay, here we go. There is a chart here, but the point of this is, between 2009 and 2014, per capita growth in healthcare spending in California grew at a compounded annual growth rate of 4%, exceeding the 3.6 compounded annual growth rate in the state's overall economy. Now, that's only a 0.4% difference. Since then, we know that that number is actually much bigger from 2014 out. It's growing at much higher rate than 0.4%. But even with that 0.4%, if we had some targets here, had California achieved healthcare cost growth in line with economic growth, consumers and taxpayers would have saved nearly $56 billion with 4.4%, or almost 5% of the total healthcare spending in the period. This represents a meaningful and achievable portion of the staggering 20 to 25% of waste that experts found in the system. So I'm not trying to be punitive here. I'm trying to get people to act, to work smarter, be more efficient, eliminate waste, and reduce the growth in the cost of healthcare. With that, I respectfully ask for your aye vote.
Thank you. We do have a motion in a second. Clerk, please call the roll.
The motion is to pass as amended to appropriations. Wood?
Aye.
Wood, aye. Mays?
Aye.
Mays, aye. Aguiar Curry? Aguiar Curry, aye. Bigelow? Bigelow not voting. Bonta? Bonta, aye. Burke? Burke, aye. Carrillo? Carrillo, aye. Flora? Flora not voting. Mainshine? Mainshine, aye. McCarty? McCarty, aye. Nazarian? Nazarian, aye. Rivas? Rivas, aye. Rodriguez? Rodriguez, aye. Santiago? Waldron? It's 11-0.
It's 11-0. Your bill is out. Moving on to item number, if I can see the number, item number 20, AB 1131. Dr. Wood.
Thank you very much, Mr. Chair. AB 1131 addresses the gaps in the existing health information exchange infrastructure, an infrastructure that is inconsistent and incomplete.